Yeah, why don't we get started? Well, I want to thank you all for being on the call. Sort of our first sort of formal thing that we're doing for our second wave for MARQUIS 2, which is fantastic. When we've done this previously, it often took a while for sites to get up and running with data collection, and so the fact that you're all on this call right now means we can really hit the ground running with data collection, which is such a crucial part of this study. So again, thank you for your flexibility with your schedules, for being here, and hopefully some of you got to do the homework as well, look at some of the slide decks, the intro slide decks in advance, so that we didn't have to cover as much of that kind of material today. We could really get into the mechanics of how to do this whole process. So here's what we're going to do. We'll do some introductions. We'll review, or at least just answer any questions you have about the pre-webinar slide deck that we sent all of you. We'll do a broad overview of the logistics of how we do data collection. And then we'll spend the rest of the webinar talking about the most important phase, which is how to take a gold standard medication history. And then we'll do a role play, taking the medication history. And then we'll wrap up and we'll preview webinar 2. And helping me lead this is Stephanie LeBonville. And Stephanie, you want to introduce yourself?
Yeah. Hi, I'm Stephanie LeBonville, and I've been working with Jeff since 2001 on this process of trying to improve medication histories and all that goes along with it, from admission to discharge and transition thereafter. I'm a clinical pharmacist and started working in general medicine and have kind of transitioned into the pain realm, but also with a big focus on medication histories and medication as well.
And Stephanie and I have been working together really since I came to the Brigham in 2001, and has really been an integral part of all the studies that we've done to look at med reconciliation and pharmacist involvement in improving med safety during transitions of care. And certainly a national expert in her own right in this area, and has really been involved in training pharmacists how to do this kind of process. Now dozens of hospitals across a number of different studies. So we're thrilled that she was able to join us again on the team this time around. I'm Jeff Schnipper. I'm a hospitalist at the Brigham. I spend about 10 weeks a year on the general medicine service, working with the residents and the medical students, and then I spend the rest of my time improving trends of care at the administrative level at the Brigham and at Partners Healthcare, and then mostly doing grant-funded research in improving transitions of care, improving medication safety, improving med-rec communication among providers, between providers and patients. And so this work is definitely in that sweet spot of the stuff that I do. And I'm a principal investigator for MARQUIS 2. So we'll go around the horn and see who's here. So from McLeod Regional Medical Center in Florence, South Carolina.
Patty Main. I'm one of the clinical floor pharmacists. I guess I'll be. I'm kind of running the pharmacy technician program down at ED right now, who are getting home medication lists from patients.
And Anna Swindler. I'm the clinical coordinator of the pharmacy at McLeod Regional Medical Center.
Excellent. Welcome. And Niagara Health System in St. Catharines, Canada.
Hi, I'm Andrea. I'm the rec pharmacist that's been hired here to help with implementation in St. Catharines, Niagara region.
Is anyone else on the call with you?
No, it's just myself.
Sounds good. And from OHSU in Portland, Oregon?
Hi, I'm Charmin. I'm actually a technician, and I'm the program coordinator for our third-year IPI Pharmacy School MedRec program. Most of the students come through our MedRec program here, and I also do a good bit of hospital auditing around MedRec. So Seth thought I'd be a good person to join in with this.
Absolutely, perfect.
And then the rest of our pharmacists, our system has crashed this morning, and so they're scrambling to try to get that up. So they may join us here at a little bit later time.
Sounds good. And from RWJ in Somerset? It should Somerset. Sorry, it says Somerville. It's Massachusetts back snafu there.
That's right. This is Lou Brunetti. I'm the internal medicine clinical pharmacist here at Robert Wood Somerset, and I'm also faculty at Rutgers University.
And anyone else with you, Lou, today?
I'm Nancy Doherty. I'm the clinical coordinator of the pharmacy as well as the med safety officer.
And I'm Rajiv Shah. I'm the pharmacy resident.
Super. And from UC Davis in Sacramento, California?
Yeah, quite the crew here today. Everyone you see on the board is here along with one of our hospitalists as well. So there's about 8 of us in the room listening in.
Fantastic. That's great. So I think more people can get trained in how to do this, the better. So thanks for all being here. And then Yale New Haven in New Haven, Connecticut.
Hi. Good morning. Good afternoon. My name is Kimber Booth. I'm Associate Director of Clinical Pharmacy Services here. And I'm joined by Sarah Cohn, who is our student supervisor of our medication history technicians and our quality improvement department.
Excellent. Great. So, and then also on the call we have Shelley Potter, who's really taking the lead at the Brigham and helping us with data collection and analysis and graphing and reporting, and you'll become good friends with her. Harry Reyes, who's our project manager here. Megan Malik from the Society of Hospital Medicine, and anyone else on the call who left off. So let's get started. So first of all, hopefully some of you, hopefully most of you had a chance to review the slide deck that we gave out, which is just the introduction to MARQUIS 2 in general to try to put this work in that context. So any questions that you guys have about that slide deck? So questions about med safety during transitions of care, what can go wrong and why it goes wrong, or how often it goes wrong, the importance of med reconciliation to improving those transitions, the design and the results of the first MARQUIS study, or the design of MARQUIS 2, which is what we're doing now, including the intervention components or mentored implementation. Any questions about outcome assessment for MARQUIS 2 in general? Because obviously we're going to get into details, now. Or any other questions you guys have about the material from that slide deck?
No, just very good. I think some had been covered in prior webinars too when we were considering applying to be in MARQUIS.
Good, excellent. Yeah, so for those of you who didn't have a chance to look at it, I won't name any names. Just please look at it and review it, and definitely let me know offline if you guys have any questions about it. But hopefully that sort of set the stage for what we're going to be doing now. So good. So in terms of background, say most sites that I talk to, one of the barriers I have to improving MedRec is the lack of a good measure of its quality. Just checking off a box and saying that you've done MedRec well in no way guarantees that you've done it well, and sometimes have to check off a box because it's, say, for example, a joint commission requirement can actually be counterproductive because then you're not as transparent about the times when maybe you couldn't take a good medication history and someone else needs to, fix it the next day and take the ball and run with it. And so I think having a good measure of how high quality your MedRec process is really crucial to know where we're starting from, where our efforts need to be targeted, and to know whether interventions are actually working. As I said, I think the joint commitment metric kind of encourages what I would call pro forma compliance, i.e. checking off in a box without understanding the actual quality of the process. So the solution is to do good quality measurement, and that's why your role is so crucial, because it really does inform everything else that your site's going to be doing. So any questions or comments about that? The National Quality Forum agrees with us, and 2 years ago they formally endorsed our metric of the number of unintentional medication discrepancies per patient as its new measure of the quality of MedRec around the country, and we're now hopefully starting a 5-year journey to get the rest of the country to be doing what we're going to be doing today and what you guys are going to be doing as a Marquis 2 participant. So hopefully this will become standard of care, and every hospital will have to do some kind of low-level measurement using this exact same methodology so that they know how good their MedRec process is. They acknowledge that this is a bit of work. It's in contrast to the prevailing trends right now, which is to do as many quality measures as possible with electronic data collection only. This is clearly not that. It is as far from that as can be. It requires a lot of manual work. But they knew that it was a good deal better metric than what we had available to us right now, and so they thought it was important enough to endorse it. Let's talk about the procedure for MedRec. I'm going to turn it over to Stephanie. So here's the review of the full protocol of how you're going to measure the number of discrepancies per patient in a sample of patients at your site. So first, identify and randomize which patients you're going to see. You're only going to sample a small number of the patients in your hospitals, obviously. You're going to meet the patients to complete some basic demographic information, collect a gold standard medication history, so what really were they taking before they came into the hospital and what should they be on. Compare that gold standard history to the medical team's documented pre-admission medication list, what we often call the PAML. Compare that gold standard history to the admission orders, compare your history to the discharge orders, and look for those discrepancies. Contact providers if necessary if you're not sure why a discrepancy occurred, was it on purpose or not. And then document all your results in REDCap, which is the system that we're using to centrally collect all the data in a HIPAA-compliant, de-identified way. So what we're going to be doing today is the first 3 items on this list, and then what we're going to do for the next webinar is talk about all the others. The biggest one is collecting that gold standard medication history, which is why it takes the bulk of the first webinar to cover that. So any questions about that? So the first step is to identify and randomize patients. Ideally, you have a project manager who can help do this work. The goal is to collect data on 22 patients per month, which is on average 1 patient per weekday. You can do 1 patient per weekday. You can batch it and do a few patients a week, as long as you get to about 22 patients per month. The other goal is to try to get patients admitted on different days of the week, especially weekend versus weekday admissions, because they probably are different kinds of patients. I think if you only collect data on patients admitted during the week, you are limiting the generalizability of your findings. And so what we're recommending is that since the weekend is 7 of your week, that comes out to about 6 out of 22 of patients per month admitted on a weekend. So if you find them all on Monday, who are admitted on a Saturday or Sunday, that's great. But what sort of gets you there, over the course of a month, doesn't need to be exact on a week-by-week basis, as long as it sort of averages to that over the course of a month. So ideally, you would get a list of the patients who were admitted the day before on whichever target units and services you're going to be collecting data on. So you should be thinking about how is your site going to obtain that list. You can copy that list and paste it into an Excel worksheet. We will give you a random number table for every single day of the study. So for example, you pull up yesterday's list of patients. We give you a random number table for July 26th, and it says 5, 16, 9, 2. That means the first patient you would go to approach would be the 5th patient on your list, followed by the 22nd patient, if there is one on your list, followed by whatever it was in that order. And so that way, in a non-biased way, you pick randomly the patients that you're going to try to collect data on. If they're off the floor, if they're unable, then you should at least try again to see if you can collect data on that patient, either until you find them or until they leave the hospital. Because otherwise, if you only restrict your data collection to patients who you happen to find on the floor and are ready to talk to you, that's obviously a pretty biased sample too. So we're trying to be unbiased. you probably select about 5 patients for every patient you need to interview in case they really are off the floor and available and they end up being discharged. But hopefully it doesn't take that much effort to find the patients that you need. And if it's a project manager doing this, and once you're done with that whole process, then you would email that list of names and room numbers to the study pharmacist, who would be the one collecting the data on those patients. One word on what sort of scope of units and services you're going to be collecting data on. That's really a decision that you will make with your quality improvement team, with your mentors. And the general rule is that in place in your hospital where you think you're going to be doing interventions in the next 18 months, that should be the scope of your data collection. And that way, as you do more interventions and you spread them to as many of those different places as possible, that gets reflected in your number of discrepancies per patient in sort of a global way. We can also reanalyze the data to look just at the patients where maybe you're doing a targeted pilot intervention, and that's totally fine as well, but it should be pretty broad when you think about the total denominator from which you're going to be collecting patients for data collection. So questions about the process of identifying and randomizing patients, and we can walk you through this one-on-one, as you get started in this process.
Just one quick question. You mentioned to send the names of the patients to the pharmacist. Do you mean all 5 of the patients that were potentials, or just the one that you actually received?
No, it would be the 5 that they then would try to go see. So, yeah, no, exactly. Other questions about this process? Okay. Any questions come up, definitely, that's a good time to email us. I will also be on the call for like 10 minutes of every mentor-mentee call. So if you're on that call as well, I'll be making sure that there are no questions about data collection, and I can help troubleshoot issues. All right, so I'm going over to Stephanie, who's going to talk about how do we actually I have one more slide, sorry. So one thing you're going to do is just complete some basic demographic data on the patients where you are collecting data. So, so basically their MRN, their age, the admission date and time, the date that you're doing this process, the date that you're taking the history yourself, that's the comparison date time, the location or unit in the hospital, what service they're on, their admitting provider. Later you can fill out the discharging provider if it's different. If you are already starting to do interventions, then you would write down whether they're a control or an intervention patient. Some of your sites may be doing an intensive level of intervention in patients who are high risk, and so you would want to note that as well. And if some of your sites already have dedicated history takers, say, for example, pharmacy technicians in the emergency department, you would note that down as well. And all of this is on the header of a form that you'll be filling out and then eventually entering into REDCap, so it's not sort of a surprise what data you need to collect on these patients. And with that, then you go into collecting the gold standard history. So any final questions before I turn it over to Stephanie?
Hi, I'm Booth from Yelm Haven Hospital. Just a clarifying question about that last comment about whether the history is taken by a dedicated history taker. So if one of our interventions is having pharmacy technicians in the emergency department, for example, do we need to then audit their history that they've taken by a separate pharmacist? Or does the
That's exactly the point, is that a lot of you are going to have programs where you have dedicated history takers, but the point is that we don't know whether they're doing a good job or not. And in fact, we found at a number of our sites, including my own, that even if you train people how to take good medication histories, doing all sampling, you're not checking over every single case they do, but you're doing a very small sample and you're doing a double check on those. You can give them feedback so they can do a better job, and we can also use it for data collection, so we know whether discrepancies still exist. So it seems a little redundant, but there's really no other way to verify the quality of the process, even if you have sort of a dedicated person doing that process. So does that make sense?
No, it perfectly makes sense. I know that the way we audit them in general is we basically observe them. This, we're saying, doing it separate as a second history, separate from the actual work, though, right?
Right. exactly. And yeah, and certainly direct supervision is, observation, works too. But yeah, this is a separate process. You'd probably be doing it like the next day, that kind of a thing after they've been.
Got it.
And the other thing is the advantage of having 20/20 hindsight. Sometimes you get better data the next day, which is not the fault of your history taker at all. But
right.
it gets us closer to the truth, and eventually lets us know, their histories need to be retaken. Because that may be a quality improvement mechanism that you put in place, is when a history taker knows that they couldn't do a complete job for whatever reason, they relay that to the intern who maybe needs to do a better job the next day. And so if that process is working well, then discrepancies disappear in the orders, and you can sort of track the process. So having a little bit of hindsight, the next day may sometimes help.
All right, thank you.
Sure, absolutely. Any other questions about this? All right. The last point there in blue, the way REDCap works is that none of the identifying information of those patients gets transmitted to us at the Brigham, but you get to keep the data internally. And at some point, we can talk about how you might download your data for your own internal purposes if you want to look at results by unit or by attending or by, that kind of information. We don't have that data, but you would have that data if you wanted to crunch it yourself. So. All right. I'm going to turn it over to Stephanie and talk about the process of taking the gold standard medication history.
All right. Thank you. So we're talking about a lot of our focus today is on taking a gold standard medication history. And I can tell from your applications and also from some of our introductions that many of you have experience with taking medication histories, and that it can be varied by site. So one of the purposes of a call like this is that we're going to standardize across the sites so that way all of us, each site, has a uniform process, uniform tools, so all collecting data in the same way, on the same page, so that way even if we've had this big experience across the sites, we'll be collecting data as a whole for a whole study in a uniform way. And that is actually brings me to my first point of who's going to be taking this gold standard medication history, and that's the study pharmacist. And the study pharmacist actually is a unique role because the study pharmacist is a key to the primary outcome of our study, which will be collecting the number of unintentional medication discrepancies, both admission and discharge. So the study pharmacist's role in this study is to actually be monitoring for the process that we have in place and to be collecting data, kind of as you may think about it, in the background to monitor the processes that are in place now and that go into place throughout the study, to be collecting that data on admission and discrepancies kind of behind the scenes so we can collect what is actually occurring. So you think of somebody already doing this process, but as we kind of alluded to just a couple minutes ago, what the study pharmacist's unique role is to really be watching our processes kind of behind the scenes, documenting our discrepancies, admission, and discharge throughout the whole process so we can see what needs to be done, so we can really collect the data on what our processes and where our discrepancies are really showing up at each hospital and as a whole. Does any questions on the study pharmacist's unique role? Okay, so let's get into that. So when will the study pharmacist really be looking to collect their gold standard medication? As soon after admission as possible, and using all the medication sources that you have available to you. If you have somebody that's already taken a medication history, you do not have to not look at that. The gold standard medication history is using all the tools that you have available to you to really get the best medication history that you can. So certainly talking to the patient, yourself, family, caregiver, pill bottles, patient's own medication list, outpatient providers, discharge summary, transfer records, community pharmacies, pharmacy database, and any other that you have available to you are certainly places that you want to utilize to get your best possible medication history. Some people have said to me, well, how come you're using the pharmacist or this role as a gold standard medication history, how come you can't just use the admitting provider's history gold standard? And really the reason is because we're standardize the process. We want to use a standardized process. We're training the study pharmacists for this role across each site, and really we use standardized tools to really collect the best possible medication history or pre-admission medication history for the patients we can. So one of the things that we'll say, okay, well, that sounds very time-intensive, and it can be, of course, but there are some ways that we'll say we can save time. So one of the ways that we'll look at saving time is we can exclude PRNs, except inhalers, and so we're not going to include inhalers, nitroglycerin, opioids, muscle relaxants, sedatives, if PRN. So other PRNs, which the pharmacist or whoever's collecting the data, if they find them not to be clinically significant, they do not have to enter them in the interest of time, such as topical lotions, maybe some nasal spray, some herbal supplements, vitamins. Certainly the pharmacist or whoever's collecting the data is certainly welcome to put them into the medication history. And if they find them clinically significant, they certainly should. However, in the interest of time, we know we don't have all the time in the world. If the person collecting the data finds that this is not clinically significant, then they would not need to include it. And we kind of ask that we say it's a study pharmacist or a clinical person, because ideally this would be somebody that could make that judgment correctly. You know, is this actually an important discrepancy or not? In the interest of time, we feel comfortable excluding that. And if you if you don't feel comfortable excluding medications, certainly you can enter them in. Question about that? It'll become, once you start doing the process, it'll become far more clear. Once you actually try to apply it to a real patient, that's when your questions will come up, and that's why we'll keep in touch with you as well. So one of the standardized tools that we have provided you, which hopefully you were able to review before this call, is our best possible medication history quick tips. Well, this is a tool that sometimes I'll even take in with me to the room, because I do want to make sure that I get a few things checked off. I want to be efficient about the matter, and I don't want to have to try and, oh, I forgot this, I'm going to come back later, because then, of course, that's not very efficient. I have to go back, wait for the patient to be available, go back in and talk to them. So I really try to get all my ducks in a row before I go into the room to talk to the patient themselves about their medication history. And this tool is helpful for me, and you may use it as well, or you may find that you want to just bring in a checklist yourself that is somewhat similar to this as well. Things that you want to remember to ask the patient in order to obtain that best possible medication history. Now, you may have already looked through this, but some of the highlights, of course, include if the patient has their own list, we're just going to be saying, yes, are these right? I see your list is here. We, of course, want to be asking probing questions, open-ended questions that can kind of provide the story, lead you down the path of getting the true medication history for the patient. Of course, we'll talk a little bit in the best possible when we go over the high performance checklist, behavior checklist at the end, but certainly this is just one of those standardized tools that you can even bring with you into the room to try to ask those important questions, open-ended questions, probing things about what the patient does take. Of standard history, actually you can go to the next slide because it will show some of the probing questions. So I don't know if you can read that, but hopefully you were able to review it before. You want to ask about medications that are easy to forget, inhalers, nebulizers, and of course, discussing the purpose of each medication, trying to get them to really explain to you what they actually do. Okay, as far as the medications go. Next, we can go to the next slide, because that's the gist of that. Now, this is going to be your meat and potatoes of what your gold standard medication history is going to be all about. Right now, of course, it looks even a little overwhelming, but it's going to become very old hat to you once you get through a few of these. So I'll orient you to the sheet today, but I want you to remember that we will be going over these again, but try to grasp what you can. The first, once you take your gold standard medication, which of course is what the patient is actually taking, and not what they're per se prescribed to take, but what they are actually taking. Of course, we do want to know what they're prescribed to take, but what the patient is actually taking is really the gold standard medication history. We can think about this if the patient is supposed to be taking amlodipine 5 milligrams or something daily, but they're not taking it, or furosemide 20 milligrams every day, but they don't take it on Friday because they have to go out, then you can see that what they actually do is what their actual regimen is. And we'll want to document that as the gold standard history, because then if the team says, let's go up on the Lasix dose, we'll want to, kind of think about, did they know that the patient actually wasn't taking it the way that they were prescribed? And we'll play out as we go through the patient cases. But just keep in mind, the gold standard medication history, as we're going to keep it, is what the patient actually does take and do as their typical regimen. We're documenting the medication name, and then DRF in the left column means dose route, frequency, including units, and drug class. The drug class really shows up under the REDCap data tool. There'll be drop-down for pick, so you don't particularly have to in what the drug class is, because when you use the tool, there'll be classes for you to select from, but I don't want you to be caught off guard that there's an extra tool, an extra field in the REDCap tool. So we mention it here on the paper form as well. You can check the box if it's PRN or OTC. That will also come to play when you enter into the data tool, and will be helpful for you as we kind of sort through the data in REDCap if you mark it as PRN or OTC if the medication actually is. Section, because sometimes there's more to it than just dose route frequency, and so we leave the comments in there for you to be able to write down something about the medication that you want to keep notes of. And there's this really tricky field in the gold standard column called additional medications. Now, try to just follow with me. Additional medication is going to always mean medication is not in the gold standard list. The column you're in, you circle additional medication. That means not on your gold standard list. Now you say, why is it in the gold standard column then? But I'll tell you that is a function of our data tool. When we enter data, we need to have something input in each of the columns. If you find a medication that you want to keep track of as a placeholder or something that's going to come up later, that under additional med in the gold standard list, and that's really a way of saying this is just my placeholder. I think this medication is going to come up in the future, but it's not on my gold standard list, so I'm going to put that in my placeholder under the gold standard column. It comes up later on admission. I want to be able to say, hey, this was not on my gold standard list, but I do need to put something in this field. This is going to come into play in our next training sessions as we go through the progression of our pre-admission medication, comparison of our pre-admission medication list, and discharge orders. And those are actually the next couple columns as you'll go along through the next couple columns. And so those are actually be covered in the next webinar, but I did want to orient you to the full columns you'll be working with. Now, each column section, or each actually row, as you would think of it, is one medication. You will have several pieces of paper likely for each patient because each row is just one medication. If you have 5 medications, then you'll have 5 rows of comparison because we do separate them out like that and follow them throughout the course of the progression through the hospitalization. And on the right-hand side, there'll be questions, pharmacist comments will also go over in the next webinar. Questions about that?
This is Rania Patel from Oregon Health and Science University Hospital. I had to join the meeting late. Is there a set of slides that you're looking at? Because I can't access the online webinar. I think it's a security thing over here.
Shelley should have sent you the slide deck. Shelley, everyone got the deck. Is that correct?
It's
not this one. I'll resend this one.
She'll send it to you right now.
Okay,
so,
thank you.
Absolutely. There's a deck that was an intro deck, and then there's the deck we're going over right now. So, on slide 15, and so by the time you get it, we'll probably be on slide 16.
Great, thank you.
Sorry about that. I can do in advance of our next webinar so you can get access to it through your security. So maybe we can talk about that offline.
Okay.
That's good. I want to go to the next slide, Stephanie.
Sure. So now we get into the nitty-gritty about what specifically we should be. Oh, there's another page on that. Okay, yes, okay. When your gold standard is complete, you do want to note the total number of pre-admission medications. That way you know how many rows you should have so they don't get lost. Document your patient's general understanding of the medications. Document all the sources used to collect history. It will come into play. You just to say how, when you go through this, say, being a discharge, oh yes, will this remind me of what I look at again, what all were my sources used. So you get that up front, mark it down what you used, and enter any general comments. After we fill out the form, you will be entering the data into REDCap, and that will be discussed in the future webinar. Enter in REDCap at that point, or you can wait until you've collected all the discrepancies across the progression of hospitalization and then enter it at that point. That's really your flow and what will work best for you, and you can kind of choose based on your site on that. Okay. We're going to get into the nitty-gritty of what things we definitely want to be asking about to make sure that we get that gold standard history. A typical day, what medications the patient takes at different times of day, if the patient receives medication prescriptions from more than one provider, obtain the contact information for each prescribing provider because you may need to contact them depending on how confused the patient is and the confused the history gets, the patient's community pharmacy or pharmacies, and mark that phone number down or the town that it's from, and how sure the patient is of medication. And who knows their medication best, because you do want to talk to that person. If the person is not the patient that knows their medication best, you would want to be speaking to the patient, or person, sorry, that knows how the patient takes their medications best. Okay? You will want to ask the indication for each medication. Sometimes that will lead you down the path of what the patient thinks, what they're actually doing, the strength, dose, and frequency of all the medications, because that's in our fields we need to fill out, how long the patient has been taking the medication, the last time the patient took the medication, has the patient taking it the way they should. And of course we want to ask that in not a judgmental way. In an open-ended question way is certainly one of the ways to say, lots of people take many medications every day, and it can be difficult. How many times a week might you say you might miss medication? How many times is not letting them say yes or no, but having them say how many times is really an open-ended question. Explanations for that non-adherence. Is it the cost, access to pharmacy, lack of appreciation for the medication, side effects? Is the patient not taking any of their medications, or have they run out because they need a new prescription? And of course, potential side effects, which also lead you down the path of the non-adherence route, or potential things that might be helpful in the medication history, like what side effects they have, and how severe are they, and what actions have been taken by the patient and prescriber. Okay? So already probably do some of these things, but one of the acronyms that I found useful are often forgotten information I use Simon Says to just kind of remind me to ask the questions open-endedly for the patients. These are ones that are often forgotten. Things that, what do you take to help you sleep at night? Inhalers do you use? What do you take for pain? What muscle relaxants? You know, if that looks like part of history, that's a good thing. But what do you take for pain? That gives me a lot of information that is not always answered at first on the medication list passed through. OTCs, of course, if you find that they're not relevant, as we discussed at the beginning, you don't have to put them down if it's something that's not clinically relevant. But certainly if you find that they're taking an OTC, allergy medication, and a prescribed one, you probably want to note that. So it's not something I'd leave off. I would say, what medications do you buy over the counter or from your pharmacy or from, you know, as non-prescription? How about triglycerides? That's one that is very important, but sometimes they forget to mention that. Stomach acid meds, aspirin, eye drops, another one they leave off. Stools, because it's an uncomfortable thing, they might just want to like not really tell you about that, might not want to open up to you about that. But certainly we've had people that readmitted for constipation, so it's an important one to ask. Certainly if it's, you know, once in a blue moon, you can leave it off, but I do approach the subject because it's what can be important. Okay. Any questions about any of what we just went over? And certainly, if you haven't reviewed that best possible medication history handout from MARQUIS, certainly do take a minute to look at that, even bring it in the room with you, because it can help you kind of remember those probing extra questions that we do want to delve into with patients when taking their gold standard history. Okay. Now, I believe we're going to move into a role play.
Yeah. So can you hear me okay?
Mm-hmm.
Great. So let's look into the role play, which is the most fun part of this. What you're going to do is take the history. Anthony's going to play the role of the patient. And I'll give you some basic patient information you might find in your electronic medical record. You should then interview Anthony, but also think out loud and ask about additional sources of information as needed. So, you'll say, oh, for example, I want to contact the pharmacy, and then we'll just give you the information that the pharmacy would have given you had you been able to talk to them. So take some notes, write down the final med list when you're done, then we'll ask them to tell us what you think the gold standard history is. We'll review it and go over tips on how to do this, completely but efficiently. Before we launch into the role play, I did want to take a brief divert and talk about health literacy. Health literacy is a problem. It definitely adds to the challenges that patients have when they are navigating the healthcare system. People don't usually tell you right off the bat that they've got low health literacy or literacy in general. A lot of them are ashamed. There are a host of avoidant behaviors they may do, like they just don't have their glasses. Many hide their difficulties. And so, possible indicators of low health literacy, like I said, they make excuses. Maybe they've got 20 papers folded up in their purse in their pocket, and the reason they haven't gone through them and gotten rid of them is because they honestly don't know how to read them. Like a follow-through with tests and appointments, seldom questions are basic in nature. They have difficulty explaining their medical concern, how to take medications. It's yet one more reason why we ask about indications, because you get a good sense of how well people really understand their meds, and that might be one barrier to them understanding their meds. But we can't always tell. Looking at someone, they have low health literacy, we sort of take a universal precautions view of this. People with normal, adequate health literacy are usually not offended by explaining things in simple terms. But on the other hand, if they've got low health literacy and you don't explain things simply, then then we're not going to be communicating clearly. So I would confirm the accuracy of the medication list with everyone. I would always look for confirmatory sources of information whenever you're doing this. Okay, so to summarize on this slide here, 26, all the stuff that Stephanie talked about and all the stuff that's in that trifold GPMH pocket card. These are all the things that we're going to want you to demonstrate now when we go through this role play, and then we'll review at the end how well you guys did collectively. So start by asking open-ended questions about what meds a patient is taking. Use probing questions to elicit additional information. So they're non-oral meds, they're non-daily meds, they're brand meds, and they're non-prescription meds. Use probes to get at things like common reasons for PRNs, getting to the Simon Says that Stephanie talked about, meds for problems in the problem list, if you have a problem list, meds prescribed by specialists, other prompts that you can use to try to get as much information out of a patient as possible. Asking adherence in a non-judgmental way that gets them to admit it as much as they're going to admit it. Use two sources of information, ideally one provided by the patient and one that you've got your hands on, so quote-unquote objective source. Know when to stop getting additional sources. So if the patient has a list or models and reliable, your data are not that dissimilar from another source that you have, and the differences can be explained, talking a good game, they can be done, right? So you've got a list, they have a list, they drive, or they can explain away the differences, then you can be done. On hand, if the patient is not sure what they're on, they're relying on memory only, so they don't have a list or their pill bottles, or cannot resolve the discrepancies among the various sources of information that you have, that's when you know that you need to get additional sources. And that probably go after pharmacy data first. That's usually one of the easier sources to get your hands on, whether that's community pharmacy data or data from like SureScripts, that's a national pharmacy database. If history is still not clear, then you're probably going to have to go further, like getting outpatient provider lists or having the family bring in pill bottles from home and do what I call brown bag rounds, where you put all the pill bottles in a brown bag and you dump them out on the bed and figure out what they're really taking. And if I do that, I always learn something new. If patients have loose medications that are outside their pill bottles, then using a resource like drugs.com to identify those medications by describing what the medication looks like. We're to the patient a second to review any of this new information and resolve any remaining discrepancies. Getting help from other team members when needed, although in your case, you're probably going to be relying mostly on yourself. And then finally, educating patients or caregivers about the importance of carrying an accurate and up-to-date medication list with them. Because, of course, if they had that in the first place, then everyone's job would be a whole lot easier the next time they get admitted to the hospital. So questions about these high-performance behaviors? All right, so let's get started. So case number one, which is the only case we're going to do today. It's Thursday, October 1st, 2015 at 9 a.m. You're going to see Victoria Kaminsky in the emergency department, working with a computer system that allows you to access electronic medical records for the patient, and the computer provides you with the information below, which is not much. You use the attached checklist of high-performance behaviors and the supplied pocket guide to help you. The patient is a 62-year-old female. That's her birth. She's in with knee swelling and pain. Her medical history includes hypertension, a history of a deep vein thrombosis, and chronic headaches. And she told lisinopril, which causes a cough, NSAIDs, which cause a rash, and clonidine, which causes a rash. And the only information we have in our electronic medical record, based on an emergency department discharge summary from 2 years ago, is that at that time she was on amlodipine 5 milligrams by mouth daily and a vitamin B complex 1 tablet by mouth daily. So you go ahead and start interviewing Stephanie, aka Victoria, and take her history. And if additional sources of information at any point, you can sort of stop and ask what you would need, and we'll give that information as well. So go ahead. Don't be.
We're just all getting something.
Anyone may the lead, but certainly it would be good if we'd have more than one participator.
Hi, this is from Yale New Haven Hospital. So basically I would start with just asking the patient open-endedly, can you just do it as a role play? Okay. Hi, Victoria. Can you, do you want the whole introduction, or or get right into the med history? Because normally we have a process where we, wristband, ask the talk to the patient.
Yeah, you can skip the wristband stuff. In fact, I think I can have that in a slide that I removed somewhere along the line, like the two identifier thing. Yeah, you just go right into the history. But play your role. Ham it up.
Okay. Would you mind telling me how you take your medications on a daily basis at home?
I know that I take a baby aspirin and amlodipine.
Okay. For the baby aspirin, do you know how many times a day you take that and what time of day?
I take that actually once a day for and amlodipine, I take that today as well, in the morning.
What's the dose of the amlodipine that you take?
I got a 5 milligram tablet, but I take 2. Yeah, in the morning.
Someone else jump in?
Yeah, sure. Super.
Yeah.
So this is UC Davis. Victoria, do you manage your own medications at home?
Yes, I do.
Okay. Do you happen to have a list with you today or happen to bring your medication bottles here with you to the hospital?
I have a couple pills in my purse. I bring them, I do have a couple pills in my purse.
Sure.
We can show them to you. There they are.
Perfect. So I'm just going to go ahead and look this information up in the computer right now and see if I can identify these tablets. Do you happen to know what these might be?
One of them I take for my headaches, Tylenol. The other one is the aspirin.
Sure. So when you take the Tylenol, how many tablets, how often do you take?
So one tablet, if I need to, if needed for pain or headaches, but usually it's for headaches.
Okay.
And I take it, a couple times a week.
A couple times a week, great. And this is your aspirin product here, and you again take how many tablets, how often?
Once a day.
Once a day. Perfect.
Do anything to verify the identity of each pill?
So I would look this information up on either eFax or Lexicom to just verify these tablets with her.
And if you did, you would get that.
Sure, I get that information. And again, I would update this in the system, and then I would probably just move on to additional further probing questions, asking if there were any, are there any eye drops that you may use at home, inhalers or topical things that you consider current?
Do use inhaler? Yes. They said I could use it 1 or 2 puffs, every 6 hours as needed, but I use it once a day. It's every day, but it's not every 6 hours.
Okay. Do that inhaler is prescribed to be taken as needed, or if you're supposed to use it skilled every day?
No, I recently had a cold. I went to some convenient care place, and they said just take it when I need it because I was feeling short of breath.
Sure.
Just whenever I needed it.
Do you happen to know the name of the inhaler or what pharmacy you may have gotten it from?
Albuterol. That's a good question. I do have a pharmacy.
Okay, and what are you getting your medications from?
Joe's Pharmacy.
Okay.
Why doesn't someone else take over? That was super.
What do you guys want to try?
Hello?
Oh, yes, I can still hear you. This is Stephanie.
Okay. Ask a few more questions?
A question. Thank you for sharing some of these medications. I see in your history that you have a history of high blood pressure, headaches, and there's also listed a history of a clot in your leg or arm potentially. Do you take any medications for that problem?
but it was several years ago, and my doctor told me I couldn't stop now that my risk period had ended. But it's been several years since I've taken anything for that.
Thank you very much. Any topical medications on your skin?
No.
Do you need to take anything to help you sleep or for other pain other than your headaches?
Do you take any medications that maybe you only have to take like once a month or once a week so it's not so often?
Samples that you get from your doctor's office?
No samples.
That's a good question. We actually should add that to our card. I'm not sure samples is on there, but I think it's a great question to ask.
Yeah.
Then I would like to confirm, can you tell me when the last time is that you took each of these medicines?
Aspirin I did take in the morning, we'll say this morning. The amlodipine I took this morning. What else did I say? Albuterol. Yes, I did use that. I haven't needed yet today. Those are the ones we've talked about, right?
Yes.
Okay, good.
Do you take any vitamins or supplements or herbals?
Oh, yes. I do a multivitamin every day. Sorry, I'm going to have to be a real patient. I'm a forgetful patient here, so that's why I'm playing that role. But yes, I do take a multivitamin every day.
And do you have something that you take every day, or do you just occasionally when you think about it, or how do you take that medicine, that vitamin?
I take it every day.
Okay, great.
In our records, show that you've taken vitamin B complex in the past. Do you currently take that in addition to the vitamin?
No, I stopped that one. I figured the multivitamin was better. More stuff.
Do you take anything to help you go to the bathroom?
I don't.
All right. Thank you for telling us when you took these medications last. And like during a week, this happens to all of us sometimes. Is there a time where you may have forgotten to take medicine in the last week? Like aspirin, how many times a week do you forget to take that?
I do remember that. I know because I use a pill reminder, and I do remember. I'm good about it. I might not know them off the top of my head, but that reminder reminds me, so I just go and do it when it dings.
Is that the same for the other medicines too?
Yeah.
So at this point, do you feel like you need to get any additional sources of information for corroboration? Do you feel like you pretty much know what she's on? What would you do next?
Call the pharmacy.
Pharmacy? All right. If you call the pharmacy, this is what she's been filling lately. So I'm peeing 10 milligrams. The 30-day supply was last dispensed 12 days ago. Albuterol inhaler last dispensed a month ago, and the vitamin B complex was last dispensed a year ago.
I feel like that would be two sources. Oh, go ahead.
Good.
Yeah. So you said that you were taking 2 of what you thought were the 5 milligram tablets in the morning, but she's filling a 10 milligram tablet.
No, 5 milligram tablet. what? All right. I don't know if you have the slide deck in front of you. Yes, it's 2.5.
Oh, okay. Oh, I see. I'm sorry. I wasn't looking. Okay.
Yeah.
Okay.
Question very detail-oriented. Very good.
Yeah, absolutely. All right. You got any other sources? Do you feel like you're done?
I reviewed just the allergies with her, just because I don't know that I trust the latest source.
Absolutely.
As far as each of those.
Yeah. Absolutely. No. And for the sake of time, we'll leave out the two identifiers and the allergies, but absolutely, clearly, definitely part of what you would want to do. So
I still think I'd want to confirm how much of the aspirin she's taking, just because some people do take like 2 aspirin or I think said 1, but just confirming. We already there are 81s, right? Never mind. We had that from the pill identification.
Right. Assuming baby means 81. Yeah, that's right.
I would also ask her who told her to take the aspirin. How did she decide to take the aspirin? Did a physician tell her?
And ask her.
That's a good question. Yeah, no, I just decided to take it for my heart.
Okay. I'll ask her. I'd also ask about side effects. You know, like, do you ever get any stomach upset? From the amlodipine, any swelling in the ankles, things like that? I would ask.
Yep. No, actually, good questions, but nothing that I complain about.
Okay. Okay. Thank you.
All right. Anything you want to say to her before we wrap up, and you can tell me what she's taking? All right. So
keep a list of your medications with you.
Yeah.
So
Good.
Oh yes. I don't have one with me, but yes, I do need to.
Yeah, that'd be great, Victoria, if you kept a list. All right. What is she on?
I guess the problem, well, we didn't really go back over this again, but when you said a best possible medication history, she would not be on the vitamin B complex.
Yep.
Even though, because it was dispensed a year ago, she's not taking that anymore. So she's on the baby aspirin, amlodipine, 10 milligrams, oral inhaler as needed, which we include in the best possible medication history, and the Tylenol twice a day.
How much Tylenol?
As needed.
And how many grams?
Yeah.
Right.
That's
Milligrams.
the identification.
Right. As needed, and then you would say how much she actually takes of it. So.
A few times.
Yeah. And in terms of documenting meds that she doesn't take at all, as Stephanie said, that doesn't go on the gold standard medication list. If you want to have a placeholder in case you think the resident is going to think that they're on it and starts ordering it, in which case it would be an additional med, that would be, something you would stick in that additional med section. And so you could just say, vitamin B complex comments, patient does not take it at all, call it an additional med, or you just wait to see if the team messed up and actually, thinks that he's on it and started ordering it on admission, in which case that's when you actually need to document it as an additional med. You always just put it as a comment to yourself on the side, in the pharmacist comment section, just to sort of note it. Otherwise, as Stephanie said, document what they're actually taking, and if how they're supposed to take it is different from that, then put that in the comments. If you could put a note about general adherence, patient takes it about 5 days a week. If somebody systematically takes it in a different way than prescribed, then how they systematically actually take it, you should put in the gold standard, but how they're supposed to take it, you would put in the comments. So again, at the end of the day, you want to document both how they actually take it and what they're supposed to be on. And so as long as you put those kinds of things in the comments, and as long as you're focusing on what they actually take, then everything you need is going to be there. So if you had asked, I would have told you what the PCP knew about the patient. Yeah, go ahead. So.
I have a clarified question about this, the best possible medication history and what the patient takes or how to take it versus how it's prescribed. And it matter. And one question I guess I'd have is with this form, do you a crosswalk to some of the common electronic health records like Epic or something? Because I have to admit that we commonly, because the PML, the Partition Med List, contains usually prescribed or dose strength, and make a note if they're not taking it as prescribed. So that's how we do it, because of how that has to be entered and how it pulls in maybe from prior visits, et cetera.
Right.
It's kind of the opposite, I think, of how we think about it, whereas the best possible medication history is actually what they were prescribed. But it's like you look at it the opposite. And I want to really
no, you're right. Epic does exactly what you just said. It tells you how they're supposed to be on it, and then if they take it differently, you note that. We want you to do the opposite. We want you to write down what they actually take and then make a note of how they're supposed to take it in the comments. And that way you're more likely to find the errors. I would say, I bottom out somebody's blood pressure at least twice a year because, the patient's prescribed 5 different antihypertensives, and I naively think that they're taking all 5, and we prescribe all 5 in the hospital, and that's the first time all 5 have ever simultaneously been in that patient's bloodstream. And so, we put the emphasis on what they actually take, and then you put how they're supposed to actually be on it in the comments. So you're right, it is the opposite that we document. So, but you'll catch more stuff that way, I think. So.
I have a question kind of in addition to that. So you talked about the vitamin B complex and that you would write a comment to your in the list or flag it as the additional med, to keep on your radar. If it's a patient-reported medication here at our institution, we can remove it from the medication list.
Yep.
Is that something that, for this study, you recommend continuing to do?
I guess what I would do, there's a couple of ways to handle this. If there's a med that's been prescribed that the patient is not taking at all, you're not going to put it in the gold standard list. And you can just leave it off and be done and just wait to see whether the team made a mistake and then document it then. And that's what we're going to talk about next webinar. How do we sort of document the discrepancies in the orders? And I think that's perfectly appropriate. If you wanted to write a reminder to yourself, like, oh, yeah, patient, in theory was supposed to be on X. It's on their list, but they're not on it at all. That's fine, too. Whatever sort of works for you. In the worst case, make sure that you don't document anything. You don't do any extra work unless it becomes a problem. But the second way is sort of a reminder to yourself. But it isn't a standard med if they're not on it at all, as Stephanie was explaining. So that's all.
Yes, thank you.
Okay. So if you had asked to what the PCP would have said if you had called them up, they would have had the amlodipine 10 milligrams, so 2 5-milligram tablets, and then the vitamin B complex on there. And if you had asked about their other prescribers, she would have told you she has a neurologist, and the neurologist has the amlodipine, the acetaminophen for headaches, and the vitamin B complex. We already showed you the loose pills. So here's the gold standard. I think you guys got it all right. So aspirin 80 milligrams by mouth daily for heart. Amlodipine 10 milligrams by mouth daily for blood pressure. Multivitamin 1 tablet by mouth daily for general health, not the vitamin B complex, which was self-DC'd. The acetaminophen 500 milligrams, 1 tablet by mouth twice a day as needed for pain or headaches, takes several days per week. And the albuterol inhaler, 1 to 2 puffs inhaled every 6 hours as needed for shortness of breath, currently using it about a puff a day. And the patient does not take the vitamin B complex. So, anybody get anything different from there? So in terms of your performance behaviors, I think you guys pretty much got it all. So let's see, you started with an open-ended question. You asked probing questions about non-oral meds, non-daily meds. PRNs took you, PRNs you did, non-prescription meds took a little while for you guys to get to the multivitamin, but you guys eventually got there. Used other probes, such as common reasons for PRNs, you did a number of those. Meds for problems in the problem list, you definitely did that. Meds prescribed by specialists, I don't know if you got to asking her whether she has a neurologist and whether the neurologist prescribes anything. I think you sort of got there. You asked about adherence in a non-judgmental way. You used at least 2 sources of information, one by the provider and one from another source, so you got the pharmacy data. Knows when to stop getting additional sources. That's not applicable in this case. You knew when to get additional sources if available because there were still some discrepancies. You weren't quite sure if the patient knew everything they were on. So then you went to pharmacy data, which is the first additional source to get to. You used a resource like drugs.com, or you mentioned a couple of others to identify loose medications. You could have gone back, do a little bit more formal, and just go over the whole list with the patient the second time through to resolve all the remaining discrepancies, but you did loop her back in a little bit. You didn't need help from other team members, and then you did educate the patient about the importance of carrying an accurate and up-to-date list of them in the future. So, super. Any questions about this?
Make one comment that I wanted to remember to mention. This is Stephanie. I heard a couple of people say, do you take something like that? And I would just suggest that in some cases it can be helpful to say, what do you take for? Because do you take is a yes or no question that is often just people really say no, whereas you can say, what do you take? And then they have to think about, oh, what do I take? So sometimes I find that helpful. It's a thing you is a yes or no. And also, I want to give a brief word on the confidence that you have when you're taking your medication history. I didn't mention this before, but it is on when we send you out this form that has the medication comparison form on it. You'll notice a column that says, how confident are you, or what's your confidence in your gold standard history list? And I'll just tell you high, medium, and low. High is, and this will be on the sheet, because on the back of page 1, it tells you, it defines what high, medium, and low is, so we all do it the same. But high confidence is patient and at least 2 corroborating sources agree, and medium is patient and at least 1 corroborating source agree, and low is and not high or medium. So I just wanted to put that word in there as well. When you come to look at the forms more in the future, you'll see that.
At the end of the gold standard process, you'll have filled out the first 2 columns, what meds are they on and your confidence in the accuracy of that med. We also ask at the end for you to do a global confidence in the list, and so this is more like how good a historian you think the patient is. The patient's very fluent in their meds, they know why they're on them, they can resolve discrepancies, they understand the indications and the directions. That would be a very high confidence kind of a person. The other end of the spectrum, I take the blue pill for my blood pressure. I don't know what it's called. I don't know how much I'm on. That would be a low. A medium is the typical person in between. So I interrupted. You had a question?
No, I interrupted you about that. So are the patients that we just completed, would you rank? I guess I would have ranked my confidence in the patient as high. However, according to the criteria that you stated, we did not use 2 corroborating sources of that would agree. So does that fit into medium?
Yeah. What do you think, Stephanie? I would probably say medium for the confidence in each individual med. Does that sound right to you?
It depends on how many. You did get the pharmacy, which would have had. And you have the loose pills, so if any of those, depends how much you actually, sources you actually did use, but for you, you did the pharmacy, the loose pills, and the patient, but actually the pharmacy didn't have any of the loose pills, so then that would be medium.
Okay.
If not in the PCP data, then you probably would have, been able to upgrade some of them to high, or the neurologist. But that's fine. Again, it's a judgment call.
This is going to be by med.
It's by med and globally. If I go back to the form, sorry.
So the confidence
in the header of the form, there's a place where you put patient understanding of medications, high, medium, and low, and that's globally. And then there's a confidence for each med, high, medium, or low, that you put there too. Because maybe specific meds where you're particularly unsure, and I think that's useful, because we can always do a secondary analysis where we remove from the analysis all the times where your confidence was low, for example, and that way, we just restrict it to the ones where we're at least medium sure that the patient was actually on their meds, or we could even exclude patients where you thought the accuracy, your faith sort of in the accuracy of the history you were able to take is low, because you just weren't able to get access to enough sources to know for sure what the patient was on. So we can run secondary analyses that way if we want to.
Yep. Can you clarify again for me? The medium is patient and another source,
and at least one corroborating source agrees. Perhaps one corroborating source agrees, and patient and at least two corroborating sources agree. That's on the med comparison form. It's written out for you, and it's in red cap. So it will you don't have to memorize that. It'll be there for you. And the global patient understanding has a slightly different definition, which is also on the form for you to just kind of look at. I can orient you to it now, but don't feel like you have to write it down unless you want to. The patient understanding, which is that global when you say, okay, this is how well the patient globally understands their medication, is high, medium, or low. High being they understand indication, dose, strength, frequency of most of their medications. Is they have inconsistent or incomplete understanding of indication, dose, strength, and frequency of the medications, but it's high or low. And low is, at most, they can really kind of identify their medications by name or patient, but not both. A little understanding of their dose. So they might say, I take one blue pill once a day. So that would be a low. And that's all written out on the form for you. But those are the patient understanding is that, and then for each medication in the form, you'll also be listing the confidence, which
I want to emphasize one point that Stephanie made about, what I call not leading the witness. Even if you've got a list, what you don't want to do is just read off every med on the list and ask them if they think it's correct, because they'll probably just nod and say yes. So much better off if you have them read back to you what they think they're taking. You're much more likely to catch discrepancies between what they're taking and what you have as your list, and you also get to assess the patient's understanding of their meds. So that's one of the things that we definitely play up as we do the training. Pharmacists are going to be, or pharmacy techs, who are going to be doing the job is, even if you've got a list, having them say, please tell me what you're on. And if they say something like, well, you have a list, don't you? And you say, yeah, but, our list can be wrong, and I really want to understand from you what you're on, and get them to report it out. So
just one last question with low, medium, high. So is it acceptable to have just two sources, so the patient and pharmacist, or should we strive for the patient and two additional sources, or is it?
No, I'd say two sources is fine if the patient is talking a good game. So if they've got a source and you've got a source and they seem reliable, so that your global assessment would be high for them, then it's fine if technically, you're medium for each of the individual meds, because technically you only have two sources, one corroborating source. That's fine. I would say only go for the third source when you have to. You can't spend all day doing these, and if the patient's talking a good game, then that's a time that you can stop with two sources. But as you've interviewed patients, often two sources is not enough, just because the patients really can't resolve the discrepancies between them and really don't know know meds well. So then you end up having to get another source. So, okay.
Patient question?
Yeah.
So for the purpose of the study pharmacists fill out the form with all the gold standard medications. But in terms of medication list that we have currently in our electronic medical record, can we make changes to those? The specific question is, if we find that there is a significant discrepancy with the medication list, can we go in and update our electronic medical record as well, so that we can prevent potential medication errors if, let's say, you know, the patient gets discharged before we intervene for like discharge reconciliation or something like that?
That's a great question, and we're going to cover this a little bit in the second webinar, but the short answer is that if you're worried about a serious error, then you're pretty obligated to tell the team, you know, as soon as you catch it. The ideal scenario is you catch the errors in the orders after all the orders have been written, including the discharge order, so you're sort of seeing the natural, you know, course of events. But if the patient is still in the hospital and the discharge orders haven't been written, but you capture, you catch a major error, then I think you have an ethical obligation to report it and to get it fixed or to fix it yourself. Usually, you end up telling the team and you know, whatever process you would normally go through to get the error fixed. Sometimes what ends up happening is you take the history. You know, the second day they're in the hospital, you end up doing the comparison to orders. You know, much later, and the orders have all been written, and so you're sort of catching the errors at that point. But even if the patient has left the hospital, if you're really worried about what the patient got discharged on, then, you know, we end up having, you know, being in a situation where you have to alert somebody so that the error doesn't get perpetuated. So, you know, this is always that tension between collecting data for data purposes and trying to interfere with usual care as little as possible, but then also, you know, we've got an obligation to fix stuff that we catch if it's serious enough. Keeping in mind, you know, if you weren't doing this data collection, then the error would have just gone on, you know, unnoticed, you know, indefinitely, which is what happens in real life all the time, right? I mean, you know, we know on average that patients have, you know, probably about a half a serious medication error per patient at baseline. It's just, and the only reason we don't walk out about it is that we're not usually detecting it. But now you'll know. So we have an obligation to report. So does that make sense?
Yes, thank you.
I would add that you do want to try to stay in the background of, in general, as your data collection. So I wouldn't tell the person unless you find a clinically significant. Like I wouldn't say to say there's a pharmacist or somebody else taking the medication history. I wouldn't alert them to the fact that you're taking the history. You wouldn't say, oh, hey, I got your patient on my list today. Just because you do want to be in the background and you don't want to interfere with usual care, you don't want them to feel like they're being AKA watched. You want them to do what they normally would do and just kind of follow the process as it go along. And certainly if something's clinically significant, you would say something, but you wouldn't be telling people or interfering in the normal flow unless you really need to.
That's right. We'll spend some more time talking about that next time. So, okay. So look up. So for webinar 2, we're going to give you some homework. We're going to give you a more difficult case. Obviously, this case was fairly simple. Patient was not on that many meds. Wasn't that complicated. But what we're going to give you is much more complex. We're going to give you all those sources of information, and we're going to give you the script that the patient would say if asked. So you've got everything in front of you. So in that sense, it's easier. It's not dependent on your skill as a history taker or knowing what information sources to ask for, because we're just going to give all that to you. But it is a patient on a lot more meds with a lot more discrepancies between the various sources. And what we're going to want you to do is fill out those first 2 columns of the worksheet for that patient. So the gold standard and your confidence in the accuracy of each med. And then we're going to use that case next time. We'll go over the answers for the gold standard, and then we're going to talk about how we're going to compare the gold standard to the team's history, to the admission orders, and to the discharge orders, and knowing when to contact the team, and know, therefore, how to fill out the rest of the form. And that's what we're going to do for webinar 2. So identify discrepancies, when to contact the team, and how to use REDCap to document your findings. And so here's a way to think about it, is we're going to do the last 5 items on this overview of the protocol, the things that we didn't cover today. So I think that's it. I think the last issue is we need to find a time to meet to do our second webinar. So please, if you haven't already done it, please complete this doodle poll, which Shelley sent out earlier today, and let us know your availability for your second training. And hopefully we can do that in the next 2 weeks, so 2-3 weeks. So then you can actually start collecting data. We know your sites will really thank you for, because like I said, so much is dependent on sort of knowing our baseline state of affairs when your sites are trying to get institutional support, and then start designing interventions and seeing if those interventions work. So I think that's, I don't know, Stephanie, anything else we need to talk about?
No, great job.
Awesome. So, not surprising. One thing that we are going to be doing, yeah, go ahead.
Would it be emailed out to us?
We'll probably we'll put them on the, are we going to put them on the HMX website, which everyone will have access to?
Yeah.
We want people
Yep.
right here. Yep. Okay. Yeah, there's a sort of a website where we can all get in, share documents with each other. There's a listserv, so you guys can ask questions of each other, including our Wave 1 sites that started 3 months before you did. So as an incentive to get people used to using that site, we're going to post it there, and you can pull it up. The other thing I was going to say is that in the fall, we're going to host a few live workshops, which hopefully as many of you guys can go to as possible, some on the East Coast, some on the West Coast, where we're going to do like a train the trainer session. How would you train your frontline pharmacy staff, pharmacy techs to take good medication histories and to verify their competency in taking histories using role plays? And it'll be really fun. So hopefully you guys, some of you guys can make that. And we'll talk about that piece because, you know, obviously being able to train other people how to take good medication histories is going to be one of the major interventions you're going to do. But all along, you're going to be collecting data by sort of doing the gold standard in the background. So I think that's it.
When will we be getting access to that HMX website? I don't know if I
immediately. Yeah, let me work on that with Megan at SHM. If we can't get you guys access to it immediately, we'll just email you the slides. But either way, we'll get you access very soon to the HMX website. So.
Okay, and this video would be posted there too?
Yep, exactly. Okay, and for anyone who
wonderful.
missed it, who wants to see it, you can definitely do that as well. So, Steph, final comments?
I want to say thank you to everybody taking the time.
Excellent. Good. All right. Well, thank you guys. Thank you, Stephanie.
Thank you.